This is a first in a series of 3 short videos concerning the use of ultrasound in the treatment of distal radius fractures. In the first one, we're going to talk about pre-op evaluation, and our example will be carpal tunnel. Conflicts of interest: I'm a stockholder with Sonics Health, and I am co-editor of the textbook MSK Ultrasound for the orthopedic surgeon. This short case series illustrates how ultrasound may be used on a distal radius fracture. This first one, of course, is the pre-op assessment. Part 2 will be intraoperative assessment, and Part 3 will be a postoperative assessment. The hand and wrist are ideal areas for ultrasound use because all of the structures are close to the skin and they're parallel to the skin, which allows us to use anisotropy and other techniques to elucidate structures. Our first patient is a 70-year-old woman with no previous median nerve symptoms, but she developed a relatively minor distal radius fracture and carpal tunnel syndrome while she was waiting in the emergency room to be seen by orthopedic surgery. You can see on the x-ray there's a thin distal fragment which would make the use of screws a little more difficult, but the articular surface is intact. In some orthopedic surgeons might think that this could be treated with cast alone, but we decided that whatever reduction we obtained would probably not be stable. So we decided to use the external fixator to control the fracture, but to look with ultrasound to see what is pressing on the nerve. The question is, do we really need to release the carpal tunnel? In this view, which is a long axis view of the distal radius, we can see a minor step off and some swelling in the pronator quadratus, which overlies the fracture. There is no hematoma, nor is there a bony fragment that might be impinging on the nerve. Here we're going to do a standard ultrasound exam for carpal tunnel syndrome. So we pick up the nerve, indicated by the arrows here, over the swollen pronator quadratus. The nerve has a normal cross-section and a honeycomb structure. At the entrance to the canal, however, which is over the lunate, the median nerve is 3 times larger by cross-sectional area and has lost its honeycomb appearance, which is a sign of swelling. This type of nerve swelling is generally seen proximal to where the nerve is being pinched. In the canal, as noted by the pisiform, the nerve in the canal is greatly decreased in its cross-sectional area. So we did a long axis view, although this is not the usual view with which to diagnose carpal tunnel syndrome, but it made such a great demonstration of the degree of compression of the nerve in this patient. It also demonstrates that she had compression of the nerve before she developed symptoms, that the fracture has just tipped her over into the symptomatic category. So we did an ultrasound release. This example is from another patient with a distal radius fracture who developed carpal tunnel while in the waiting room. The carpal tunnel release in this patient was done immediately before the application of the fixator, and the next day she had no numbness in the median nerve distribution. This time we're going to look at a patient who is not displaced but is angulated, and she developed carpal tunnel syndrome in the emergency room. This is an example of the usual hydrodissection. So this is not a patient with a distal radius fracture. This is what the normal hydrodissection looks like, which is a form of vector mathematics. You have a point of application, which is over the lunate, between median nerve and ulnar artery, and a line of application going up into the canal, being dissected with lidocaine in this case. And in the same patient, the cutting device has a point and a line of application. Only in this case, the blade is moving from distal to proximal. So let's return to our patient with the angulated fracture. We start over the pronator quadratus, and the nerve looks fairly normal, but as we progress into the hand, the nerve becomes larger, it loses its honeycomb pattern, and it becomes distorted. Let's look at it in long axis. To the right is the proximal nerve, and to the left, over the lunate, we see that the nerve is no longer parallel to the skin, and it is swollen and is increased in its diameter in terms of volar and dorsal dimension. This affects our hydrodissection. Our needle is no longer parallel to the skin, but is going down at about a 30-degree angle. And the same thing applies to the cutting device. Here we see it in short axis, and then we switch to the long axis. We can see that the nerve is no longer parallel to the skin. The device is no longer parallel to the skin. And the important point here is that we like to see the cutting device applied all along the transverse carpal ligament. And if we go any farther into the hand, this blade will leave the surface of the transverse carpal ligament and leave a space where nerves or arteries or other structures could get between the cutting device and the ligament. So in conclusion, if there's a distortion of the anatomy, particularly angulation, this will disturb our linear arrangement. And in this angulated fracture, multiple cuts were required. The first cut to cut the proximal portion of the ligament so that the cutting device could then be advanced close to another part of the ligament. And then finally we cut the distal part of the ligament. Of course, ultrasound carpal tunnel release is unnecessary if the surgeon is going to perform a more distal exposure in order to get that distal ulnar corner of the radius. Here we see the transverse carpal ligament at the level of the trapezium. It is coming from the right to the left, and the ligament splits and goes both superficial and deep to the flexor carpi radialis. This deeper branch is vertical, and therefore we really don't see it in this view, but we know that it is there. If one has to do an extensile exposure, it would follow the path of this dotted line, completely releasing on the radial side the transverse carpal ligament. So with one incision, the surgeon can increase his exposure and release the carpal tunnel. So in summary, preoperative ultrasound can be used to assess the soft tissues, and it can assess the cause of the carpal tunnel syndrome and can plan the approach and technique, and in a great many cases actually guide the procedure if an ultrasound guided release is chosen. Thank you for your attention.